الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. النهاردة هنتكلم على Non-STEMI Guidelines. المحاضرة دي هتبقى related to the European Society of Cardiology 2015 وفي updates خاصة بالدي والانتيبليتلت ثيرابي هنتطرق ليها إن شاء الله خلال المحاضرة. المحاضرة هتبقى في شكل MCQ questions وهنحاول بناء على ال MCQ questions ديت اللي هي السيناريوز اللي احنا بنشوفها خلال شغلنا ان احنا نحاول نشوف الانسر والامبليكيشن بتاع الجايد لاينز على براكتس. اول حاله عندنا is a 44 years old male patient with known hypertension, hyperlipidemia and he's diabetic. He came to the ER with a chest pain that occurs with minimal exertion and his initial ECG shows normal sinus rhythm with non-specific T wave changes in the lateral leads. According to the guidelines, which of the following is true regarding cardiac biomarkers? A. For this patient who presented within 6 hours of the onset of symptoms, an early marker of cardiac injury such as myoglobin or CKMB subform should be considered instead of cardiac troponin. B. In this patient who suspected acute coronary syndrome and negative initial cardiac biomarkers, another sample should not be drawn since the patient is pain-free. Troponin I, letter C is troponin I is preferred over troponin T due to variability in the biomarker assays, and D, total CK cannot be used alone with additional tests such as cardiac-specific troponin when evaluating a patient with acute coronary syndrome, which is true regarding the cardiac biomarkers. Well, and the right answer is D. The total CK cannot be used alone with additional tests such as cardiac-specific troponin when evaluating a patient with acute coronary syndrome. This is the flow chart of assessing a patient with chest pain who came to the emergency department. When the patient presented with acute chest pain after doing his initial ECG, you have to do a high sensitivity cardiac troponin. If the cardiac troponin marker is less than upper level of normal and is a high sensitive one, then you have to evaluate the duration of the pain. If the pain is more than 6 hours, if the pain is more than 6 hours and the cardiac troponin is below the upper limit of normal and the patient is pain-free with great risk score less than 40, and you have to exclude another differential diagnosis, then discharge this patient, and you may or may not ask for stress testing according to his initial risk factor profile. If the high sensitive cardiac troponin in this chest pain patient less than upper limit of normal and the pain is less than 6 hours, then you have to retest after 3 hours. If after 3 hours no change, then the patient is pain-free, great risk score less than 40, and there are other differential diagnoses could be implemented, then you can discharge this patient safely or do a stress testing to him according to his risk profile. On the other hand, if the patient, his cardiac troponin is upper limit of normal, and according to the risk factors, you have two options. The first option is to retest this patient after 3 hours or to go to invasive management in case of highly abnormal cardiac troponin plus the risk profile and clinical picture of this patient, as we will see later. If this patient has been tested after 3 hours and the change is even one value over the upper limit of normal, you have to go directly to invasive management according to protocols we'll see later. If there is no change in high sensitive cardiac troponins, so you have to work up differential diagnoses to the high troponin levels. And this is another diagram that you can use if you don't use the 0-3 hour diagram. You can use the 0-1 hour diagrams in order to rule in the patient or either keep him in observation. So to summarize the guidelines points, it's recommended to base the diagnosis in a short-term ischemic and bleeding risk stratification, and you have to combine the clinical history, the symptoms the patient presented with, vital signs and other physical findings, and ECG laboratory results. So combination of all these will lead to you the good and the appropriate workup for this patient. The 12-lead ECG should be obtained 10 minutes after the first medical contact. Either this medical contact was in an outpatient, even if it is in ambulance, زي ما بيتعمل في دول أوروبا وأمريكا طبعا، هو بيبقى في الأمبولانس في ECG could be obtained. When a primary health care center or when the patient initially presented to the hospital, only 10 minutes the ECG should be obtained in patient with chest pain and should be sent to an experienced cardiologist or a physician who can interpret this ECG. If in case you can obtain a 12-lead ECG, recurrent symptoms or diagnostic uncertainty, you repeat this ECG. And a class 1 indication to do V3R and V4R when V7 and V9 for this patient when the 12-lead ECG is unremarkable, or if you suspect posterior RV infarction from the standard 12-lead ECG. When the patient presents to ZR, you have to measure the cardiac troponin with sensitive or high sensitive assay, and the result should be ready in less than an hour. A rapid rule-out protocol, as we have seen before, with 0 hour and 3 hour is recommended if high sensitive cardiac troponin tests are available. Another protocol is the 0-1 protocol, which is recommended if high and sensitive cardiac troponin tests with validated 0-hour algorithm. Not all the troponin tests are validated for the 0-1 algorithm. Special tests are available in most hospitals. Additional testing after 3 to 6 hours is indicated if the first 2 troponin measurements are inconclusive and the clinical condition suggestive of acute coronary syndrome. And this is based on the chest pain in the first place, based on the clinical history of the patient, and also based on the ECG, which maybe have some inconclusive finding, but which is concomitant with acute coronary syndrome. It's recommended to use established risk score for prognosis estimation, as we have seen before, like the GRACE risk score, TEMI risk score, and PROGNOSIS risk score, as you know. When you admit the patient, use a bleeding score, and the validated score is the Crusade score, which may be considered in patient if you are going to intervene in. What's the next step when you do the initial assessment? So, if the patient has no recurrent chest pain, normal ECG, and normal level of cardiac troponins, but you still suspect acute coronary syndrome, you can refer the patient for non-invasive stress imaging. Better we do non-stress imaging, not just stress ECG. Okay, and the class 1 indications, the echocardiography is a mandatory in assessing the patients with chest pain presented in the ER. It's very important. As the new guideline and these last guidelines put the multi-detector cardiac CT, which can be considered as alternative to invasive angiography in patients with low to moderate likelihood of coronary artery disease, not all the patients, and when you have an ECG and troponins which are inconclusive. And this was regarding the initial assessment and risk stratification of the patient. The next case, 67 years old male patient presented to the ER with chest pain on exertion. He is hypertensive, hyperlipidemic, and on medication. He is known on all medication, and he is an ex-smoker. His examination is unremarkable. The ECG at admission showed deep T-wave inversion at the pericardial leads and no Q waves. He was admitted in the ICU with IV heparin and nitroglycerin infusion. The first troponin I was 1.4, which is high according to the test. His echo revealed anterior and apical hypokinesia, which is the next step for this patient. Letter A, low-level exercise ECG stress testing next morning to continue IV infusion, increase his beta blocker dose, and add a calcium blocker until completely of chest pain for 24 hours and discharge. Letter C, you do a coronary angiography for these patients, 72 hours followed by whatever indicated PCI or CABG. You do a dobutamine echo or myocardial perfusion scan within 48 hours for this patient. The last one is continue IV infusion, increase his beta blocker dose, and add a calcium channel blocker until completely free of chest pain for 24 hours, then transfer to a repetition program. Which one will you choose for this patient? Well, and the right answer is C. You do a coronary angiography within 72 hours followed by PCI and CABG if indicated. And this is according to the risk profile of this patient and his presentation. You have to stratify the patient into groups. The low risk groups, high, intermediate risk groups, high, and very high risk criteria. The very high risk criteria are the hemodynamic unstable patient or the patient presenting with cardiogenic shock is considered a very high risk criteria. If the patient had recurrent or ongoing chest pain, even if you give him optimal medical treatment. The patient developed an arrhythmia, life-threatening or cardiac arrest. Patient present with mechanical complications as detected by echo. Patient with acute heart failure and with recurrent dynamic STT changes, particularly with intermittent ST elevation. If the patient developed intermittent ST elevation, these are the very high risk criteria. The high risk criteria are the rise or fall of cardiac troponins compatible with MI, the dynamic STT changes, symptomatic or silent, grace risk score more than 40 is considered high risk criteria. The intermediate risk criteria are diabetes alone, renal insufficiency, left ventricular ejection fraction less than 40%, or patient with congestive heart failure, early post-infarction angina, patient with history of intervention, either PCI or CABG, and the risk score may be more than 9 but less than 140. And if the patient has no any other criteria of the above, then the patient is the low risk criteria. According to what you have stratifying the patient, and you manage to find the diagnosis of non-ST elevation acute coronary syndrome according to the ACG and clinical symptoms. If the patient presented to the PCI center, if he is a very high risk, go for immediate invasive strategy within 2 hours. If the patient is high, then he can go for early intervention within 24 hours. If with intermediate, then less than 72 hours invasive strategy, you can transfer the patient. What about the low? The low has 2 choices. You can go for invasive or you can go for non-invasive testing if appropriate. If the patient presented to non-PCI center, if he is very high, you have to transfer him immediately to the PCI center. If he's high, same day transfer within 24-hour transfer. If the patient is immediate, you may be somewhat reluctant to transfer him, but you have to transfer within 72 hours. And the low risk profile patient may go non-invasive testing or option transfer, and you have seen before the low and intermediate risk patients, you can go for non-invasive coronary CT angiography. The next patient is a 60 years old male treated by PCI, which is the following is not correct regarding the peri-procedural anticoagulation. So you have a 6 years old male patient who was treated by PCI. What anticoagulation would you give this patient? Letter A, an anticoagulation should be administered to all patients undergoing PCI. Letter B, administration of IV unfractionated heparin is useful in patients undergoing PCI. Letter C, an additional dose of enoxaparin should be administered at the time of PCI for patients who received last subcutaneous dose 12 hours or more prior to PCI. The appropriate diagnostic test to check the level of anticoagulation with unfractionated heparin is the activated clotting time, the ACT. The last point, fondaparinux might be used as an anticoagulation to support PCI, which is not correct from all these choices. Well, the correct answer is E. Fondaparinux might be used as an anticoagulation to support PCI. The right is that fondaparinux should not be used to support the trial, and the guidelines state as class 1B in patient on fondaparinux undergoing PCI, a single IV bolus on unfractionated heparin should be given to the patient during the procedure. Our next patient, a 57 years old man admitted to the ER with chest pain and elevated cardiac biomarkers. His ECG showed ST depression in the inferior leads. He is a smoker with no chronic illnesses. His examination was unremarkable. Lab values were within normal range apart from high LDL cholesterol and triglycerides. He was referred to the cath lab and PCI was done to the LCX with drug-eluting stent. Which of the following is true regarding long-term anticoagulation? What anticoagulation you can give for this patient? Letter A, warfarin is recommended for 12 months. Apixaban 5 mg BID for at least 1 year is recommended. No need for long-term oral anticoagulation. Rivaroxaban 2.5 mg BID is recommended for at least 12 months. Rivaroxaban 5 mg once daily is recommended for at least 1 year, which is true regarding the long-term anticoagulation. Well, the correct answer is D. Rivaroxaban 2.5 milligram twice daily is recommended for at least 12 months. And this is according which stated as a class 2B in non-STEMI patient with no prior stroke or TIA at a high ischemic risk as well as low bleeding risk receiving aspirin and clopidogrel, low dose rivaroxaban 2.5 milligram twice daily for approximately 1 year may be considered after discontinuation of parenteral anticoagulation. This means that the patient could be discharged on triple antithrombotic treatment on aspirin, clopidogrel for example, and also rivaroxaban 2.5 milligram. Our next patient is a 62 years old man hospitalized for non-STEMI and underwent invasive strategy with drug-eluting stent. Which of the following about antiplatelet therapy is incorrect? Letter A. Patients on an aspirin should be given non-enteric aspirin 3 to 5 milligram before PCI. After PCI, use of aspirin should be continued indefinitely. Additional aspirin with a dose of 81 to 325 mg is recommended in all patients on chronic aspirin therapy before PCI. A loading dose of a P2Y12 receptor inhibitor should be given to a patient undergoing PCI with stenting at the latest after completion of PCI. In patients receiving a stent, either a BMS or drug-eluting stent, during PCI for ACS, P2Y12 receptor inhibitor should be given for 12 months, which is incorrect regarding antiplatelet therapy in this patient. And the correct answer is C. An additional aspirin, 81 to 325 mg, is recommended in all patients in chronic aspirin therapy before PCI. You should not give the patients aspirin loading again if the patient is on chronic aspirin therapy. Another patient, 66 years old male hospitalized for NSTEMI, was successfully treated with drug-eluting stent for a subtotal lesion in the LAD, which is the recommended minimal duration of dual antiplatelet therapy according to the guidelines. Letter A, 1 month, or 3 months, or 6 months, 12 months, or 24 months, which is the minimal duration of dual antiplatelet therapy for this patient. What do you think? Well, and the correct answer is D. 12 months is the minimal duration with patient non-STEMI and treated with drug-eluting. And this patient, after 4 months, developed severe low back pain with peripheral neuralgia for which disc prolapse surgery was recommended, which is a strategy regarding dual antiplatelet therapy in this patient with non-STEMI treated with drug-eluting stent. What will be your strategy regarding dual antiplatelet therapy for non-cardiac surgery? Letter A, continue aspirin 81 mg and clopidogrel and send the patient to surgery. Stop clopidogrel and continue aspirin 81 mg. Stop post-dual antiplatelet therapy and send the patient to surgery. Or you can postpone surgery for at least another 2 months. Stop aspirin, continue clopidogrel 75 mg and send the patient to surgery. Which will be your strategy regarding dual antiplatelet in this patient? Well, and the right answer will be stop clopidogrel and continue aspirin 81 mg. All these antiplatelet therapy we discuss here in this particular patient. The timing for elective non-cardiac surgery in patients treated with dual antiplatelet after PCI, you can easily interrupt P2Y12 inhibitor after PCI for elective non-cardiac surgery. After 1 month, if the patient have high ischemic risk features, no high risk ischemic features, 1 month you shouldn't interrupt the P2Y12 inhibitor. After 1 month to 6 months in the class 2A level of evidence B, you can interrupt. Class 2B level of evidence C, you can stop up to 6 months. After 6 months, you can stop and continue aspirin and send the patient for the non-cardiac surgery. Another patient, a 70 years old lady admitted with a diagnosis of non-ST elevation myocardial infarction in a non-PCI capable center. Due to her stable condition, a conservative strategy was adopted. Which of the following dual antiplatelet regimen is not recommended at discharge? Aspirin, 81 milligram once daily, and clopidogrel 75 milligram once daily. Aspirin 100 milligram once daily, and clopidogrel 75 milligram once daily. Aspirin 81 milligram once daily, and prasugrel 10 milligram once daily. Aspirin 81 milligram and ticagrelor 90 milligram twice daily, which is not recommended at discharge for this patient. And the correct answer is C, aspirin and prasugrel 10 milligram once daily. To sum up for the dual antiplatelet therapy for these patients, the guidelines stated that aspirin is recommended for all patients without contraindication at initial oral loading dose of 150 to 300 milligram in aspirin naive patients who had not been using aspirin before. You can give 150 to 300 milligram, and the maintenance dose of 75, which is the lowest dose you can give for this patient, and the maximum dose is 100 milligram per day, which is long term, irrespective of the treatment strategy. Either the patient continue in medical treatment, if the patient done coronary angiography or PCI or CABG, whatever, the long term dose for aspirin is 75 to 100 milligram per day. A P2Y12 inhibitor is recommended in addition to aspirin for 12 months, and this for all patients with non-ST elevation myocardial infarction, unless there are contraindications, such as bleeding, for example. The doses are ticagrelor 180 milligram loading dose, then 90 milligram twice daily, in absence of contraindication for all patients at moderate to high risk of ischemic events. Regardless of initial treatment strategy and in chronic dose, pre-treated with clopidogrel. If the patient have been given a loading dose of clopidogrel, you can give him ticagrelor as well. Prasugrel, which is 60 milligram loading dose, 10 milligram daily dose, is recommended in patients who is proceeding to PCI if no contraindication. You can give a clopidogrel loading dose of 300 to 600 and 75 milligram daily dose in patients who cannot receive either ticagrelor or prasugrel who have required or who require oral anticoagulation. I mean, at this point, ticagrelor and prasugrel have been put before clopidogrel in patients with non-ST elevation acute coronary syndromes if they have undergone invasive strategy, and ticagrelor is preferred if the patient done stenting. Clopidogrel still has its role, but in especially in patients with oral needs oral anticoagulation, and this is to be discussed later. But clopidogrel has its role, and you can give the patient, if no contraindication, either the ticagrelor or prasugrel. In a class 2B, the P2Y12 inhibitor administration for shorter duration of 3 to 6 months after DS implantation may be considered in the patient with high bleeding risk. In patient with high bleeding risk, and you are monitoring the patient, and you cannot monitor the patient closely, you can give him dual antiplatelet therapy for 3 to 6 months. It is not recommended to administer prasugrel in patient in whom coronary anatomy is not known. It means that if the patient did not receive coronary angiography, and if you don't know what is the coronary anatomy for this patient, you should not give prasugrel. In other words, in patient with conservative strategy, patient receive only medical treatment and discharged on medical treatment, they can be given either ticagrelor or clopidogrel, but prasugrel should not be given. In intravenous antiplatelet therapies, the glycoprotein 2B3 inhibitors during PCI should be considered as a bailout situation only, and should be used as a routine anticoagulation or antiplatelet therapy during PCI. The cangrelor, which is given IV, should be considered or may be considered in P2Y12 inhibitor naive patients undergoing PCI. It is not recommended, as we have said before, that the glycoprotein 2B3 inhibitors in patients in whom coronary anatomy is not known. Also, if the patient did not receive coronary angiography, you should not give him glycoprotein 2B3. P2Y12 inhibitor administration in addition to aspirin beyond 1 year may be considered after careful assessment of the ischemic and bleeding risk of these patients. And we have to implement a risk score to make a decision, precise decision, to continue your antiplatelet therapy after 12 months or not. There are two scores mentioned in the European Society of Cardiology guidelines. The first is the precise dual antiplatelet score, which is done at the time of coronary stenting. You can assess two strategies: short dual antiplatelet therapy, 3 to 6 months, versus standard long dual antiplatelet therapy, is 12 to 24 months. And these are the items of the score. And you can calculate and you give the patient it's his score, then you calculate the score and you decide according to score more than or equal 25, then short dual antiplatelet therapy is preferred for this patient. If the score is less than 25, then standard long dual antiplatelet therapy should be done. And this is a website for each scores. The DAPT score, and this is the most used, it should be used after 12 months. It means that the patient has received coronary angiography, done PCI, patient was on a medical treatment, whatever, and he has finished his 12 months dual antiplatelet therapy without events, without bleeding events, and without any complications. And you assess the standard 12 months versus long dual antiplatelet 30 months. Okay? These are the items of the score, and then you calculate the points. The point range from -2 to 10, and if the patient more than 2, long dual antiplatelet therapy is preferred. Score less than 2, standard dual antiplatelet therapy is 2. And the guidelines recommend the use of score, dual antiplatelet therapy score, before deciding dual antiplatelet therapy regimen. The B2Y12 inhibitor selection and timing according to the update of the European Society of Cardiology guidelines in patients with acute coronary syndrome, ticagrelor 180 mg loading dose, 90 mg twice daily on top of aspirin is recommended, regardless of initial treatment strategy, including patients pre-treated with clopidogrel. Okay, and this is almost like the previous one, but it's 1P. In patients with acute coronary syndrome undergoing PCI, prasugrel 60 mg loading dose on top of a 10 mg daily dose on top of aspirin is recommended for B2Y12 inhibitor naive patients when done ST elevation acute coronary syndrome or initially conservatively managed STEMI if indication of PCI is established, or in STEMI patients undergoing immediate coronary catheterization unless there is a high risk of life-threatening bleeding or other contraindications. It means that this was changed a little bit. You can use in STEMI patients, but this is not our topic today. Pre-treatment with a B2Y12 inhibitor is generally recommended in patients on whom coronary anatomy is known and decision to a PCI is made, as well as in patients with STEMI. A class 2A in patients with this non-ST elevation acute coronary syndrome undergoing invasive management, ticagrelor administration 180 loading dose 90 mg twice daily, or clopidogrel 600 mg loading dose 75 mg daily dose. If ticagrelor is not option, should be considered as soon as a diagnosis is established. It means that ticagrelor here as a class 2A had been given the upper hand before clopidogrel. In patients with stable coronary artery disease, pre-treatment with clopidogrel may be considered if the probability of PCI is high, and is for stable coronary artery disease. Clopidogrel 600 mg loading dose, 75 mg daily dose on top of aspirin is recommended in stable coronary artery disease patients and in acute coronary syndrome patients who cannot receive ticagrelor or prasugrel, including those with prior intracranial bleeding or indication for oral anticoagulation, and this is class 1A. The clopidogrel dose 300 mg loading in patients less than 75 years of age, 75 mg daily dose is recommended on top of aspirin in STEMI patients receiving thrombolysis, and this is for STEMI. In non-ST elevation acute syndrome patient in whom coronary anatomy is not known, still prasugrel should not be given, and this is recommended in 2015 and still ongoing to 2017 update for antiplatelet therapy. And when you shift between clopidogrel and prasugrel ticagrelor, there is some settings. When you shift from clopidogrel to prasugrel, you give loading dose of 60 mg prasugrel. Okay, and when you shift from prasugrel to clopidogrel, you give a clopidogrel loading dose of 600 mg 24 hours after the last prasugrel dose. What if you shift from clopidogrel to ticagrelor? If you are shifting from clopidogrel to ticagrelor, you have to give loading dose of 180 milligram, irrespective of prior clopidogrel timing and dosing. When you shift from ticagrelor to clopidogrel, you lose the patient with 600 milligram 24 hours after last ticagrelor dose. However, when you transfer, when you switch between prasugrel and ticagrelor, you give ticagrelor loading dose 180 24 hours after last prasugrel dose, and you give prasugrel loading dose of 60 milligram when you are shifting from ticagrelor to prasugrel 24 hours after the last ticagrelor. And this diagram is very important in the setting of patients with PCI or in setting of a patient with continued medical treatment, if you are shifting from clopidogrel to ticagrelor or in the other side. Now to another patient, a 54 years old lady admitted to CCU with a diagnosis of non-ST elevation myocardial infarction. She had a previous history of mitral valve replacement 4 years ago. With warfarin therapy, 7.5 milligram BO. She also had history of hypertension and a previous history of cerebrovascular stroke 2 years ago. Her lab values showed INR of 2.3, elevated cardiac biomarkers, and normal other values. Due to ongoing chest pain, an invasive strategy was adopted, and PCI to the LED was planned. Which of the following stents is preferred for this patient? A bare metal stent or a backtaxil drug-eluting stent, a bioabsorber scaffold, or a sirolimus eluting drug-eluting stent? Which stent do you prefer for this patient? And the correct answer is D. Sirolimus eluting stent should be used in this. The same patient received a drug-eluting stent implantation in the LED. The following regimen is recommended as charged regarding her antithrombotic management. A. Aspirin 81 mg, clopidogrel 75 mg, and warfarin for 6 months, then dual therapy for another 6 months. Aspirin 81 mg, ticagrelor 90 mg twice daily, and warfarin for 1 month, then dual therapy. Aspirin 81 mg, clopidogrel 75 mg, and warfarin for 1 month, then dual therapy for 11 months. Clopidogrel 75 mg once daily and warfarin for 1 year. What do you prefer as an antithrombotic management for this patient? Receiving a drug-eluting stent, she has a mechanical valve, and she has to receive antiplatelets and also an anticoagulation. And the answer will be A. Aspirin 81 mg, clopidogrel 75 mg, and warfarin for 6 months, then dual therapy for another 6 months. According to the guidelines for management of patients on anticoagulation, the patient, when you receive a patient with non-STEMI or OUE that has STEMI, and the patient has an indication for oral anticoagulation, you have to go through some steps in these particular group of patients. First, when you refer the patient for PCI, it's preferred to use the radial artery over the femoral artery to reduce the bleeding complications in these patients. And also, the use of new generation drug-eluting stents, that, as we have said, that the sirolimus eluting stent over a perimeter stent should be considered among patients requiring the oral anticoagulation strategy. You have to put some strategies to avoid the bleeding complication in those patients. First, you have to assess ischemic and bleeding risk using validated risk predictors, the SHAD-VASC score, the ABC, and HASP scores, with a focus on modifiable risk factors. Keep triple therapy duration as short as possible. Dual therapy after PCI, for example, or anticoagulation and clopidogrel, to be considered instead of triple therapy. Consider the use of novel anticoagulant instead of the vitamin K antagonists when novel anticoagulants are not contraindicated. And not this in our patients, she has a mechanical valve, so you are you have to use warfarin. But if there is no contraindication for novel anticoagulants, you should use them instead of warfarin. Consider, if you are using warfarin, a target INR in the lower part of the recommended target range, and maximize time in therapeutic range, more than 65 to 70 when VKA is used. Consider the low novel anticoagulant regimen tested in approval studies and apply other novel anticoagulant regimens based on drug-specific criteria for drug accumulation. It means that you have to monitor the kidney function, tailor the dose according to the creatinine clearance and the age of the patient and the indication for anticoagulation. Clopidogrel is a P2Y12 inhibitor of choice. You should use the clopidogrel instead of ticagrelor or prasugrel. Use a low dose of aspirin, less than or equal 100. Routine use of PPI is preferred. Which patient you should not combine oral anticoagulant and antiplatelet therapy? The patient with short life expectancy, for example, for cancer or something like this, patient with ongoing malignancy, poor expected adherence or compliance of the patient on medical treatment and follow-up, poor mental status. If the patient has an end-stage renal failure, patient with advanced age, these group of patients may have a high bleeding risk. Prior major bleeding, prior hemorrhagic stroke, you should not combine oral anticoagulant and antiplatelet therapy in this group of patients. Patient with chronic alcohol abuse, patient with anemia and a clinically significant bleeding on dual anthropic therapy before. If the patient has a history of this, do not use combine anticoagulants and antiplatelet therapy. And this strategy for using in patients with were compliant to use dual antiplatelet therapy. And first, you have to with concerns about ischemic risk prevailing, concerns about bleeding risk prevailing. If the patient, you put in mind the ischemic risk more than the bleeding risk, you can use for 1 month aspirin, clopidogrel, and oral anticoagulant for 1 month triple therapy, 1 month triple therapy, and also in patient with prevailed bleeding risk. But in some group of patients, you can use dual therapy only, clopidogrel and oral anticoagulant dual therapy up to 12 months. Okay. You can extend aspirin, clopidogrel, and oral anticoagulation triple therapy up to 6 months. After 6 months, you use clopidogrel or oral anticoagulation or aspirin or anticoagulation only for 12 months. After 12 months, you use oral anticoagulation alone. In other patients with bleeding risk more than ischemic risk, you can use after 3 months this clopidogrel and oral anticoagulation, aspirin, oral anticoagulation dual therapy up to 12 months. After 12 months, you use oral anticoagulation alone.